we've got Jessica here at the front, Dr. Jessica Simon, who's a palliative care physician with Alberta Health Services, and she's at the Department of Oncology at the University of Calgary, and a physician consultant with Alberta Health. Alexandra, sitting on the couch here, is an education consultant with Alberta Health Services, and her focus is, at least judging by her degrees, is social work. Jennifer, in the corner over here, is also an educational consultant with the Alberta Health Services and the Advanced Care Planning / Goals Care Program for Calgary, and her background is that of a registered nurse. I'm not sure which of Alexandria or Jennifer are going to go first, but in either way, you're probably going to want your slides, aren't you?
All right. Yes, so I'm Jennifer. Thank you so much for the introduction. And myself and Alexandra and Dr. Simon, we're just thrilled to be here. So thank you for having us. And can you hear me? Am I show? Okay, I will try. So it's really wonderful that we're able to connect with this group in November, because Kelly actually contacted us because of this new initiative between Prostate Cancer Canada and the Movember Foundation, looking to find ways to support advanced care planning amongst people with prostate cancer and their families and their caregivers. So it's really in line with our work, helping to promote advanced care planning across Alberta, outside of cancer, but for all of us. So we're absolutely thrilled to be here, because any opportunity we have to get the word out, we're jumping at it. So we really, really appreciate the opportunity to come and talk to you. Yeah, so just to get the ball rolling, we like to just start off by doing a quick check of the room and just see how many of you have heard of advanced care planning before? Just by a quick show of hands. Okay, and how many of you would say you've had an advanced care planning conversation with your loved ones? Okay, so not too bad, maybe like 30%. So back in 2012, a national survey was done, and it showed that only 2 out of 10 Canadians even knew what advanced care planning was. Okay, it's a pretty vague term. And it also showed that less than half of us had actually had a conversation with our families about our health care or about medical treatments we may or may not want. So I'd say we're doing a little bit better by the temperature check in the room. We still have a ways to go. So our goal tonight is just to give you a little bit more information about advanced care planning and help support you in actually starting this process with those who are close to you. So tonight's presentation time, we're splitting between myself and Alexandra and with Dr. Simon. So we're going to chat for about 20 minutes about advanced care planning. So unfortunately, we don't have the time to go into the amount of detail that we normally would. So our game plan is we just want to go through some of the core content about advanced care planning, kind of what it is, why it's important, who should be doing it, a little bit about personal directives, and how it all fits in with the healthcare system. And then we wanted to make sure that we left a good portion of our time to really walk you through some other resources out there to help you how to advanced care planning. So we want to make sure you know where to go for more information so you can actually put the things that we talk about into practice in your own life. Okay, so I'll have to keep checking here. So just to make sure that everybody understands what advanced care planning is, it's a pretty vague term, but basically advanced care planning, it's about making a healthcare plan now in case you were to become ill or injured and unable to speak for yourself in the future. It's basically a way to let those people close to you know what you would want with respect to your health if you weren't able to speak for yourself. Okay? And it involves thinking about your wishes, talking about your wishes, writing them down, and choosing someone to speak for you if you couldn't voice those wishes on your own. Okay?
This is actually what you do when you make a will.
So a will's different. So, and Alexandra's going to talk a little bit more about the legal documents.
But you make that decision in your will as well.
And okay, so a will's for after you've died, and it's more for your estate. So you might know a little more about that.
Yeah, a will is Jennifer, as Jennifer said, is after you die. So it does not take an effect after you die. What we're talking about is while you're alive. If you can't tell someone what you want, then it's the personal directive that's followed. A will does not take part while you're alive.
You're absolutely correct, but you do a personal directive at the same time.
Yes,
Yes.
if you go through a lawyer, sometimes you, and we'll explain the difference between the legal forms, but sometimes you do them together. Not always, but sometimes you do. Yeah, absolutely.
I certainly did.
Good for you. Yay, we got one. So who is advanced care planning for? Most people associate advanced care planning with end of life. They think only people who are facing end of life need to worry about having an advanced care plan in place. But it's actually for all adults. Alberta Health Services is recommending that anybody over the age of 18 can start doing this and can start getting the legal forms in place. Because ultimately, none of us can predict what our future health is going to look like, and none of us know what's going to happen tomorrow. So we all need to be thinking about our healthcare wishes and what we would want, so that way we can get a plan in place. Okay. My computer's not keeping up with this, so that's why I have to keep checking, sorry. So when we talk about why we should start advanced care planning, we explain that it's a gift. Like when you really get down to it, it's a gift. It's something great that you do for yourself, and it's a gift that you give your loved ones. And I've done this talk before, and I've actually had doctors stick up their hands and say, it's actually a gift you give your doctors too. So we just like to, kind of put that in your back pocket as well. But when it comes to why it's important for you to do it for yourself, it's a way for your health wishes to be known, okay? If you were to all of a sudden wake up tomorrow in the hospital, unable to communicate and unable to have any say in the decisions about all the healthcare decisions that were being made around you at that moment, if you had someone in your life that knew what you wanted and could speak for you, that's a huge peace of mind. Being able to say, yes, I have that in place, it just gives you peace of mind and relief. So it's really a great thing to do for yourself. It also gives you control over your health. Sometimes in a situation where you feel like you don't have a whole lot of control. It can be empowering, and it can lead to having better healthcare experiences because you're able to think about what you want and be more involved in decisions with your healthcare team. Okay. And when it comes to end of life, if you would rather pass away or die at home or in a hospice versus in an acute care hospital bed or an intensive care unit, making sure that you're voicing those wishes can have a huge impact on your quality of life when time is running short. Okay? So with respect to your loved ones, advanced care planning is a gift because it gives them some guidance if they ever are in the position where they have to make healthcare decisions for you. Okay. Research has been done around this, and it shows that family members who were involved with advanced care planning have significantly less distress and less anxiety about those decisions. And actually that portions of the bereavement process are easier. Okay. So with advanced care planning, it's a great way to protect your loved ones from questioning decisions that they had to make for you and carrying that burden with them for the rest of their lives. So it's just such an amazing thing. Closer? Yeah. I'm obviously not used to performing. Oh, wow. Okay. Perfect. Okay. And on that note, I'm now going to pass it over to Alexandra, and she's going to walk through the 5 steps that are actually involved in advanced care planning.
So on this slide, we have the 5 steps. So they are think, learn, choose, communicate, and document. So what does that mean? The first one is think about what your wishes and values are. So you can ask yourself, what's important to me? What are the conditions under which you would or would not want certain treatments? Where would you want to be cared for? The second step is learning about your own health. So that involves asking your doctor, what are my choices? What kind of treatments do I want? Or explain the treatments to me. So it's a discussion with your doctor about what your condition looks like and what your options are. The third step is choose, and that is choose someone to make decisions and speak on your behalf. So when you're choosing someone to be your agent and to speak on your behalf, there's some things that you need to think about. Think about who would be best to do that? So who knows you best? Who can communicate clearly in a stressful situation? Are they willing to stop or refuse treatment? Are they willing to act as your agent? I have a lot of people who do a personal directive and put an agent down, and they've not even asked that person if they want to be their agent. And the other one is, are they aware that you've named them as your agent? Step 4 is about communicating your healthcare wishes, values. So communicate with your family, communicate with your healthcare providers, your physician. Step 5 is document your healthcare wishes and appoint your agent in a personal directive. So just to take a poll, I think we went backwards. How many people have a personal directive? Yeah, we're doing good. All right. So 82% of people say that it's important to put their wishes in writing, but only 8 out of 10 Canadians do not have a written plan. So I'm going to talk a little bit about the personal directive, what it is. So a personal directive is where you would document what your wishes are regarding your health care. And you can also, it's not only about healthcare, it's also about personal decisions. So if you have any religious wants or needs, that's the place where you could put it, is in your personal directive. Just a reminder, in the province of Alberta, you need 3 documents. One's a will, the other one is an enduring power of attorney, and the third is the personal directive. The will is for after you've died, and it's got to do with your estate and property. The enduring power of attorney has to do with money. And the personal directive is what we're talking about today, is where you put your healthcare choices and name an agent. So there's a blank form that we're going to give in your handouts, and it looks like this. And it goes through step by step how you can fill one out. So you don't necessarily need a lawyer to fill out a personal directive, and this is free, it doesn't cost you anything. Just a reminder, the first sheet is actually an instruction sheet, and the second part of it is the actual document. So the 3 important points to know about it is that to name an agent, write down your healthcare wishes, and give people copies. Because if people don't know you have a personal directive, it's kind of like you don't even have one, because it has to appear so that people know who your agent is and what your healthcare wishes are. So remember that the blank form, when filled out, becomes a legal document once it's signed, witnessed, and dated. So for more detailed information on how to do a personal directive, you can follow the instructions that is included in your package today, or you can call the Office of the Public Guardian Trustee for a complete kit. And you can also go on the Office of the Public and Guardian's site, and they have videos about why it's important to have a personal directive. And just a note, you can also go to your lawyer and have a personal directive filled out by your lawyer. And just a reminder, if you have a will and enduring power of attorney, most of the time people also already have a personal directive. So it's good to go home and check your documents to see what you have. So another reminder is that to make sure that your agent has a copy, and that your healthcare givers, in terms of your physician and your healthcare team, also have a copy. So now Jen is going to talk a little bit how advanced care planning fits in with the healthcare system.
Okay, so when any of us access the healthcare system, we're hoping to get care that's in line with our values. We want the treatments that we're being given, and hopefully we're not getting any treatments that we don't want. Okay, so that's Alberta Health Services' overarching goal, so represented by the blue arrow. We want to give you the care that you want. So when we're in the healthcare system, conversations tend to become more medically focused, what we call goals of care conversations. So more centered around, your illness, your prognosis, appropriate treatments, benefits, risks, outcomes, those sorts of things. But the main point of this slide is to show that the green bubble, the advanced care planning conversations, so your wishes, your values, what's important to you, is that that's an equally important part in giving you the care that you want. And this slide here, so in Alberta, what we use to ultimately guide decisions regarding your care is called a goals of care designation order. Okay, it's a medical order written by a doctor, sometimes a nurse practitioner, and it's basically a code or a shorthand category that healthcare professionals use to communicate with each other decisions about your treatments. Okay, and so up at the top on this slide, that's where the goals of care designations order are. Now, I'm going to show a video that goes into more detail about them, but the point of this slide is that that's just the tip of the iceberg. What needs to be the foundation of that one decision is advanced care planning, because we need to make sure that that order is reflecting what you want. It all goes hand in hand with giving you the care that you want. And that happens by involving your healthcare team in your advanced care planning conversations. Okay, so it's important to talk with your family, but it's also important to keep your healthcare team in the loop too, so that you can get the care that you want. Okay, and so on that note, in that same 2012 survey that I mentioned earlier, 80% of Canadians had said that if they were seriously ill, they would have wanted to talk with their doctor about their treatment wishes. But only 9% had. So we know that typically people aren't initiating advanced care planning conversations with their healthcare professionals. It's just not being done. We also know, based on research, that as patients, we're expecting our healthcare professionals to bring it up with us. Okay, we're putting the onus on them. But the problem is that sometimes doctors and healthcare professionals aren't wanting to bring it up either. So it might be a little bit hard to read the text here, but yeah, so there's the doctor saying, there's no easy way I can tell you this, so I'm sending you to someone who can. Okay, so that's sometimes what we're finding, and I'm hoping that maybe some of you have had different experiences. Some doctors are amazing at bringing this up, but there's also a lot of barriers facing healthcare professionals too. So part of our work is to work with healthcare professionals to encourage them to be bringing this up more routinely, but we also want to empower you to be bringing up advanced care planning with your healthcare professionals. And a great way to do it is by bringing a copy of your personal directive. Okay, it's a great way to open the door and get the ball rolling. So just about those goals of care designation orders that I mentioned, I'm going to play a video. It just gives a nice overview as to what they actually mean, and they do a way better job explaining it than I can.
Goals of care are designations used by your healthcare providers to describe the general aims of your healthcare and the preferred location of that care. Decisions about goals of care usually arise over time through conversations between you, your family, or loved ones and your healthcare team. Your goals of care designation guides your healthcare team to provide timely care that is both medically appropriate and reflects your personal values and wishes. There are 3 general approaches to care or goals of care: resuscitative care, medical care, and comfort care. In resuscitative care, the main goal of care is to prolong life by curing or controlling your health condition. This means that doctors and nurses could use intensive medical and surgical interventions, if these are needed, to keep you alive and could be expected to cure or control your illness. In medical care, the goal of care is also to prolong life and to cure or control your health condition, but without the use of resuscitative care and the ICU. Medical care can be appropriate if your health condition is such that intensive or resuscitative care such as CPR and a breathing tube are unlikely to work. Or your wishes and values about healthcare may be that you would not be accepting of these intensive medical treatments. For example, if they are unlikely to restore you to a state of health that you would want. In the medical approach to care, your doctors and nurses will provide tests and treatments for any treatable problems that may arise. When your health condition or your values and wishes reflect a goal of maximizing comfort and relieving symptoms, this approach is called comfort care. Your doctors and nurses will give you medicines and other medical treatments to help control uncomfortable symptoms such as pain, trouble breathing, or feeling sick to your stomach. The main goal is not to prolong life, it is to maximize your comfort. Resuscitative treatments are not used. Comfort care does not mean that you receive less care. It means the focus of your medical care is on quality of life and reduction of symptoms. It's helpful to keep in mind your wishes and to know about your own health condition when you are discussing goals of care. Talk to your healthcare team about which goals of care designation best reflects your wishes and health circumstances.
So we're just going to review what we saw in the video. So we went through medical care, resuscitative care, and comfort care. So the most important thing to remember about the goals of care is that it's not set in stone and that it can be changed. So when your values change, when your medical condition changes, your goals of care can also change. Oh, sorry. So in line with that, how many people have heard of the green sleeve before tonight or have seen one? One person? Two people? So this is what the green sleeve looks like. And what it is that Alberta Health Services provides you with this this lovely green folder to hold all your documents that pertain to advanced care planning. So what should go into your green sleeve is a copy of a filled out personal directive, a completed goals of care order form, and an advanced care planning tracking record. So what you need to remember is the personal directive is what you fill out, the goals of care designation is what the physician fills out, and the advanced care planning tracking record is what the physician fills out or anybody on your medical team that discusses advanced care planning with you. So the key points to remember is that this is your property, the green sleeve. It's to be kept with you. So it should be kept at your home or on your refrigerator, around your refrigerator, so that if you have a medical incident, the EMS knows where it is. So the other point is to take it to appointments with you. So, and also when you go into the hospital, take it with you. And the most other important part is that when you leave the hospital, make sure it also comes with you. So think of this green sleeve as your healthcare passport. So this is the passport that communicates to your healthcare team what your wishes are. So the next slide is, don't wait, the time will never be just right. So start now while you're well. Take a green sleeve home with you tonight. You have everything in the green sleeve that you need to get started. And also we have some resources to help you with that start. So we're looking at 3 websites. The first one is the Speak Up website, then the Conversation Project website, and the Alberta Health Services website, Conversations Matter. And we have a handout with all those websites on it. The first one is the Speak Up website. All right, okay. I think we've got all the information on there. The Speak Up is the Canadian national site for advanced care planning. Advanced care planning is working collaboratively with Prostate Cancer Canada with the True North Initiative, which is an initiative for men with prostate cancer to do their advanced care planning. So Speak Up has a planning guide on the website that's specific to cancer patients. So they have a how-to book. They have a workbook that you can fill in and print off. They have conversation starters in terms of how to start the conversation with your family, how to start the conversation with your physician. So there's some really great tools on that website. It includes personal stories from patients, families, and healthcare providers. And Speak Up is also looking for champions to spread the word about advanced care planning to men with prostate cancer, so you can empower other people to take control of their health care. And I'll let Jennifer go on with the Conversations Project.
So another really good website is the Conversation Project. I found when I did my personal directive, I actually went and redid it after looking at some of these. So this one's really good. as well. It has an interactive workbook, so when you're on the computer, it actually walks you through step by step how to set yourself up for success for a conversation. It's really practical, and I found it really, really helpful. And I know even throughout our presentation, we talk about answering these huge questions like what's important to me or what are my healthcare values? And even as a nurse, I was like, what? I didn't really even know how to answer that myself. And this website has these where I stand scales and what matters to me statements that you fill in that really help you break down those broader concepts and actually articulate the sorts of things that are important to you. So I found it really, really helpful. There's also some conversation setup tips. So it just walks you through thinking about where are you most comfortable having a conversation? At the kitchen table, on a drive, on a walk? Who do you want to talk to? When's a good time? So just those real practical elements about having a conversation. There's also a really nice collection of personal stories on there. So information is fantastic, but it's so powerful to hear other people's experiences, and you can really learn from that. So that's a really great element to this website as well. And then they also have a really handy how to talk to your doctor kit. It just kind of goes through ways you can bring this up with your doctor. There's little scripts if you find that helpful. And there's like a little medical dictionary to break down some of the medical terms that you might hear in these conversations, which is really nice as well. It skipped. Okay, so we've lost a slide in the transfer here, but also Alberta Health Services, it's on the handout that you can take home tonight, but we have our Conversations Matter website, so it's conversationsmatter.ca, and there's lots more information about the 5 steps of advanced care planning that we touched on tonight. Walks you through those steps in detail with questions to help guide your thinking. There's conversation starter scripts in there, more detailed information about the goals of care that we touched upon tonight. There's links to videos. There's also links to all of the resources that we touched upon tonight and more. Okay, so unfortunately we lost our slide, but it's a really great resource. And in the green sleeve, there's actually a Conversation Matters guidebook, and it has links to the website, and it has all of that information in a bit more depth as well. Okay, so that's another way that the green sleeve is a resource for you. And yeah, so again, the green sleeve has just about everything you need to get started. Okay. So there's our Conversations Matter website, and we also have an email address, a provincial email. So if you had any other questions, you can always fire off to the email as well. And that is the end of our content piece. Yeah. So yeah, thank you very much.
So thank you, Jennifer. We'll just have a quick stretch break because I'm going to switch topics and talk about palliative care. And what I'm hoping to do is just dispel maybe some of the myths that people have about what palliative care is, who might find it useful, how do we use it. And I think a lot of people worry, is this going to be, I've lost my audio. I didn't do anything. Can you still hear me? I'll just speak up. So it's not going to be all doom and gloom, but I think a lot of people worry about that. When they hear the word palliative care, they think, is that just for people who don't want treatment for their prostate cancer? Or is that just for people who are close to dying and I don't need to hear about that right now? Or is that a place where people go to die and I'm not going to need that because I'm going to be living and dying at home? So there are a lot of myths about what does palliative care actually mean. So what I'm hoping to do is really briefly cover off what really is palliative care. It's none of those myths. Why is it important for all of us as adults to learn a little bit about what palliative care is? What sorts of services are available here in Calgary and the surrounding area? And how might I use these services? And how do we access them when we do need them? So I haven't lived with prostate cancer, and I don't know what you're all living with and your families, but I am privileged to work as a palliative care doctor, and I meet a lot of people, a lot of men, and I learn from them about what it's like to live with prostate cancer. And I witness the kind of roller coaster that people can often find themselves on in receiving a diagnosis, in learning about their prognosis, what's likely to happen, the highs and lows, the hopes, the dashed hopes, the renewed hopes, and the reframed hopes with the different treatments that people use, and the kind of good days and bad days that people have with prostate cancer. So I appreciate it's not the kind of roller coaster you want to line up at the theme park and go on again and again. And palliative care, in essence, is an added layer of support. And I was interested that you've dropped the word support from your mutual help, but it's an added layer of support for people and their families who are living with any sort of serious illness or life-limiting condition. It's a bit of a seatbelt for the ride. And while each of us have a different kind of experience with this, and no one knows exactly what you're going through, you draw on each other's experiences here at Prostate in your conversations, and your doctors and nurses and other care providers have at least walked beside someone who's had prostate cancer, even if we haven't experienced it for ourselves. So, defining palliative care. This is the World Health Organization definition. It's a bit wordy, but I thought it was worthwhile to show and to just go through. So number one, it's an approach. What does that mean? Well, it's not a particular care service. In fact, all the healthcare providers that you meet should to some extent have some idea and experience of offering up that approach. It's really, when you read this definition, a definition of good medical care. So it's about improving quality of life for patients and their families who are facing problems associated with a life-limiting illness. And it's about prevention, not just reacting to the problems that occur, but trying to prevent them, trying to anticipate what can we put in place to help smooth out some of these bumps in the road. And it can happen early. You can find the palliative care approach useful right at the time of diagnosis or at different times during living with a chronic illness like prostate cancer. And it's not just about pain and some of the other symptom issues. So sometimes people think, well, palliative care, that's for if you've got pain. Pain can be an issue, and palliative care can help address that. But there are also a lot of psychological issues, social issues, financial issues, spiritual issues. And so palliative care really is attending to all of those other issues. I guess in essence, it's kind of good medical care, and it's everything in addition to your cancer-directed therapy, whether that's chemotherapy or androgen abatement or whatever. What's important is that palliative care, what it's not. It's not about giving up. It's not about hastening end of the life. It's not an inactive or passive treatment. It's an active treatment, an added layer of support to people who are living with serious illness. And who provides palliative care? Well, as I said, probably if you're seeing an oncologist or a family physician, they're providing some of that palliative care approach to you. They're asking not just about, I hope, not just about your physical symptoms, but about some of the issues, other issues that you're living with. And so anybody on your care team, social worker that you might meet, nurse that you might meet at the Tom Baker Cancer Clinics, are hopefully providing some of that palliative approach to you. But sometimes people have quite complex issues that are difficult to deal with, complicated pain issues, nausea, difficult conversations around goals of care. We heard about advanced care planning. Sometimes these are very emotional conversations to have or hard to have. You have family members who all disagree about the best way that you should be living. And sometimes it's helpful to have a palliative care specialist meet with your family and help them to hear your voice about what's important to you. And I'm indebted to a Professor Emeritus from Geriatrics, Colin Powell, for this concept of the fact that we don't have to go blindly forward. When we get a diagnosis of any illness, I think it's important that at least we're offered a bit of a roadmap. What's this? What might this look like? We're not always ready to look at the roadmap. We don't always want to know what's coming or what might be coming. But I think to be at least offered that roadmap is important for each of us. And palliative care, again, we've seen a lot of different ways the route can go. So we can tell you about the silk route or the coarse woolen route. If you want to make this choice, this is what it might look like, and at least provide some of that idea about what is to come in your own disease. Why do we do that? Well, we think it helps people to live well with their cancer. So we know that knowledge can actually reduce anxiety and fear. So dispelling some of the myths, or letting you know what's to come, can help people to plan and have that control back again over what is to come. And the honest conversations can often actually diminish the sense of being alone and increase hope. Because you may be thinking something very gloomy, and we're able to say, you know what, actually, this is how we're going to address that problem if it arises. Most of us need a community. I think that's why prostate exists because most of us need a community to live well. And being prepared, so being prepared for the worst, hoping for the best, doesn't mean we're ready to die or ready to stop trying all the things that we're doing. It's just another way of helping us to live well with our cancers. This is an exercise I do with medical students and residents when we're teaching them about palliative care, and we're talking about this concept of having a roadmap about knowing what is to come in your illness. And I say to them, this is London, where I grew up. This is London Underground. I don't know how many of you are familiar with the map. Okay, so can you point to where Southgate is? Just roughly, all of you, point to where you think Southgate is. There you go. So London are here. But, you know, for most of us, well, we're going to go Southgate. That's probably somewhere down there, right? And how wrong we would be if we're not given a little bit of indication about where we are on our own disease. It's going to be very hard for us to make the decisions that are going to help us and help our families. So what's a cancer roadmap look like? Well, this is going to be different for each of you in the room, but it's something that you can go and discuss with your own family doctor or your own oncologist and say, you know, tell me where I am. But this is one kind of typical symptom map around the cancer experience. So when people are first diagnosed, there's often a lot of issues. You know, the fear, the anxiety, and the emotions that go with it. Sometimes there are symptoms when we're first diagnosed. And people may need help with some of those symptom issues. There's also survivorship, where our needs may be less, but there's things that we're still perhaps living with, some of the chronic symptoms of having prostate cancer. And then there's also a lot of symptoms that can arise with recurrence. If we develop bone pain, bone metastases, it can be quite symptomatic, and there may be a need for increased support during those times. There's often a lot of chronic, we think of prostate cancer as a chronic illness. And so, again, there's some symptoms during living with chronic illness. And as we approach the end of our lives, it's very common for us to have increased disability, increased dependency on others, and that's what people typically think of as where palliative care comes in. But in fact, palliative care can be helpful at any point on this trajectory and into bereavement for our family members. So palliative care includes symptom management, caring communication, and it's provided to all patients living with serious illness from the time of diagnosis to the time of death and beyond for family members. So when might I use palliative care services? The answer is at any of these time points. It's not dependent on how long you have to live till the end of life. It's dependent on what my needs are and who can best serve them. Are they going to be best served by a different line of chemotherapy, some radiation treatment? Are they going to be best served by meeting with a social worker who can help me with my financial concerns, meeting with a nurse who can help me with my advanced care planning? It really depends on what you're experiencing. And this on the left here is a description of what good medicine is. It's sometimes ascribed to Hippocrates, but it was actually apparently a Dr. Edward Trudeau who coined it in the 1800s. He had a tuberculosis sanatorium, and he said, to cure sometimes, to relieve often, to comfort always. And that's what palliative care is about as well. If we can reverse and change what's happening to you, we will do that. If we can't change what's happening to you, we'll at least help to comfort and bring support through that time. Where is palliative care provided? So it's this nebulous concept of good medicine. Where are we doing it? And the answer is wherever you are, I hope. So palliative care can be provided in your own home. If you're living in a care facility, it can be provided there. If you're in hospital or in hospice. And I'll just briefly describe those different the different services that are available in those different care settings. So I work in hospital. I work at the Foothills Hospital as a consultant there. And we will see people who are admitted to hospital who've got particular needs, usually symptom issues, and try to resolve those for people and to get them home again. And there is a palliative care unit at the Foothills Hospital. There are also units of focus at Peace Lockheed, at Rocky View, at South Health. And the Tom Baker Cancer Centre, of course, I'm imagining most of you are familiar with. And there is a palliative consultant who works there as well, who can come and see people at clinic visits if there are particular issues. And we run a complex cancer clinic, complex cancer care clinic there as well. It's a big mouthful. When you're at home, palliative care is provided by the Palliative Home Care Service. These are nurses who will come out to visit at home, support patients and their families, care coordination, equipment you might need in your own home to make life easier. They can coordinate home care aides who can come in to help with personal assistance, washing, bathing, things like that. And then, of course, your family physician remains essential throughout living with any illness. There's also a rural palliative care team for those who are living outside of Calgary. In long-term care, we have 2 nurse specialists who visit the long-term care facilities and 2 palliative consultants who again provide support if you're living in a nursing home, supported living environment. And then there are hospices, which I think people classically associate with the word palliative care. I don't know, a quick show of hands if people have had friends or families in a hospice or have visited a friend in hospice. So just under half of you may be familiar with that. There are 7 hospices in Calgary, and these are unique residential settings. These are set up with very skilled care staff who are able to help people and their families who are approaching the end of life. And it's not just about the physical care. Again, it's about the emotional, spiritual, and kind of full support that people need to live well. We don't go to hospice to die. We go to hospice to live well if we can't get the care that we need in our own home setting. So it's not the resort of the destitute, but another useful tool in your toolbox if you're finding it hard to live at home. How do we access palliative care? Well, primarily through a referral from a doctor. So if your family doctor thinks, you know what, the set of issues you're dealing with are a little bit more complicated than I can manage on a 10-minute visit to the doctors, I'm going to ask palliative care to get involved. That does not indicate that you're end of life. It indicates that you've got a serious condition that's going to need a little bit of extra support. You could be at any part of that cancer journey and needing that extra support. Your oncologist also may say, you know what, I'm going to ask palliative care to get involved. I can see that you've got issues that are beyond what we can deal with here in the Tom Baker Cancer Centre clinic. And you can also self-refer. I'll just quickly go through that. So the quickest way to access palliative care is through a referral from your own doctor. But sometimes you need to lead your doctor. So just in that cartoon that Alex showed that said, you know, this is a hard conversation, I find it difficult to have. Sometimes your doctors will find it difficult to talk about palliative care. And they'll say, I'm not sure, am I going to upset you by bringing up this word? Because they're thinking, like many of the public think, that palliative care is for the very end of life. So you might have to re-educate your doctor and say, you know, I was at a session and I heard that if I've got pain or financial issues or concerns or emotional issues I need support with, that palliative care can help me. What do you think? And then they'll go, oh yes, right, okay. You can self-refer as well, but that's probably the slowest way to access it because this number is just a general home care number. And they will take a few weeks to kind of cotton on that perhaps the issues that you're needing are not those needed from general home care, but that you're needing a consult support from a nurse or physician to come out to your home and think about the palliative care issues in your own home. So it's a bit of a slower way to access. I wouldn't recommend it unless you're struggling to find help through one of your existing care team members. What about where we replenish ourselves? Well, clearly you're doing that already by coming to an event like this. And there are a lot of other community resources. I think you're familiar with most of these. I can see the Wellspring brochures sitting around. So I don't know if any of these are new to you. I'll maybe run really briefly through them. So Wellspring, offering fantastic programs as well, kind of complementing what you're already doing here. Hospice Calgary runs something called the SAGE Centre, which is a day program for people living with cancer. Again, peer-to-peer support. Again, the same kind of idea of interesting lectures and different activities. The Family Caregiver Centre and Canadian Virtual Hospice. Canadian Virtual Hospice may be the only one you've not heard of before. This is a fantastic website. So if you've got a question at 2 in the morning, and you're wondering, who's going to answer it for me, you'll probably find the answer on Canadian Virtual Hospice. A lot of different issues about living with life-limiting illnesses. Again, support for families as well as for patients. Stop me if you are familiar with all of these things. I don't want to tell you stuff you've heard before. I think you've probably heard about the psychosocial services at the Tom Baker Cancer Centre. I was looking at some of the lectures you've had before, and I saw that that had been mentioned. Again, you can self-refer there. They run different sorts of counselling, group counselling, individual counselling, family support. Spiritual well-being is also important when living with any sort of illness. I don't necessarily mean religion, but again, the Tom Baker Cancer Centre has spiritual care services available to people if you're grappling with some of the bigger existential issues about meaning of life. Where is this all taking me? There's also the Healing Arts Programme, which is quite new at Tom Baker Cancer Centre, and I brought information about all of these things. They're at the back if you want to take anything away. Again, a self-referral, a different sort of way of, a non-medical way of living well. So I'm going to wrap up there because I want to leave time for your questions. I think one of the things that Palliative Care tries to do is to nurture hope. And for ourselves, what matters most to us along the way, what do you need to know and have in place to support you? And then for your healthcare providers, we're always wanting to know, how do we best care for you? We don't want to give people treatments that they don't value for themselves. So you're going to hear us ask you, how do we best care for you at this time? There are a lot of existential issues with living with any illness. This is a nice poem I'll just let you read. But there's also a lot of humour. And this is Will Ferrell. 98% of us at some point will die. So we recognize that each of us is unique. We each have unique needs. Our own definition of what is a good life, what is a good death, that's different for each of us. Palliative care is not one size fits all. And whether you see death as something to be battled, accepted, acknowledged as a normal part of life, denied for as long as possible, meeting someone who works in palliative care might allow you to explore your own definition and to kind of bring some clarity of that to you and to those around you. So that's, I guess, in a nutshell, what it's all about. If you're looking for some of the information, again, there's a website. Alberta Health Services has a website for everything now. This one's a little difficult to find, and I gather they're going to change the, the Google address or whatever it is. But if you search palliative care on myhealth.alberta.ca, you will find these new resources. And I just want to thank one of my colleagues, Bert Enns, because a lot of these slides came from her. So I think we should now open this up to questions. You may have lots of burning questions.
Well, I was going to say, I had a little brush with palliative care this summer with my brother, and I'm just thinking in terms of what Alex and Jennifer said about the advanced care planning. I could have done some of that, but certainly let me formally thank you, and then we'll do the questions. But thank you very much for coming and for sharing what I think is tremendously important information for us all. Anyway, thank you. I think we'll take it to questions.
Yeah, so questions for any of us, we can sort of sit and take them. So go ahead, sir.
Yeah, you had mentioned for getting into one of these programs that the referral by your family physician. Well, I've been a bit of a problem in the last 10 years or so. My family's physician has just sort of fizzled out. He's in the same multifaceted clinic, but I rarely ever get a chance to actually see her. And this whole idea of a family physician, it has sort of gone by. I mean, my older doctors, I go in and, I mean, you could relate. Now, it doesn't matter almost who pops out of the door or comes in. I feel I just don't have that rapport. The only one I do feel are closest to is my oncologist. And I feel, I discuss most things with him.
That's
So-
a very common experience. I think for many people, the oncologist becomes the primary go-to, and that's a shame. I'll tell you why. We're focusing more and more now on trying to keep family doctors in the picture, so that they are trying to get the letters that are coming out of the cancer centre to the family doctor. The reason being is your oncologist is a fantastic source of support while you're visiting the Tom Baker Cancer Centre. If there comes a time when you're no longer going there, it's back to your family physician, and if you've lost that contact with them, it can be very hard to recreate that rapport just when you need it. So we're encouraging people now to try to maintain the relationship both with the oncologist and with somebody outside of the cancer centre as well, if you can. And it's not easy. It's not easy, and you're quite right. Many clinics you go, it's a different face you see each time.
My family physician to me is a post office box where all the information is fed through. So I'm assuming it's all there.
So your oncologist certainly, though, can refer you to Palliative Care. They will frequently do that. So if you are looking for some extra layer of support that you haven't been receiving, to bring it up with your oncologist, and they know how to refer to Palliative as well.
Jennifer, nursing homes, we know there's a huge long waiting list. When you need it, can you get into hospices when you when you feel it's necessary to convince someone to make a referral, or your family thinks that it's time for you to be out of the home and this is a better place to live? And I loved your expression, you go to a hospice to live well, if you can't cope at home. Instead of people thinking you go there to die in dignity. So, and can you select one? You know, and can you, like going to a nursing home, go round them and say, well, this is where I like to go?
Yes. Good. Again, an excellent question. So yes, we're quite well served with hospices here in Calgary, probably better served than most cities across Canada. So our waiting time to access hospice is in the matter of days, not the weeks and months that it is to access long-term care. We do prioritise people who are at home because we know they haven't got access to that 24-hour support. So if you're at home, you're waiting a few days. If you're in hospital, you may find yourself waiting a week or longer, just depending, because we're prioritizing those who are at home. And there is some choice in hospice. We ask people to tell us 3 if they can. They're scattered around. I didn't show a map, but they're scattered around Calgary. People tend to pick the 3 that are closest to home so that friends can visit or other people close to them can visit. If there is only one hospice you want to go to, you will be waiting longer because they may not have a bed when you need it. And so there is choice, but often for people, the time that you need hospice, it's sort of, you know what, I need it now, and it's no longer it's not as important to me as I thought it was going to be where it is. It's the fact that that specialised care is available to me when I need it. So choice is there depending on how urgent your
you can go around.
And we actually encourage people to go around and to go while you're well, because I think, again, the unknown is more frightening than the known. So people will often go themselves or send a loved one to go for them and say, you know, take a look, what do you think? And they offer tours, volunteers show people around the hospices. They each look different, but the philosophy is the same in hospice. It's about providing comfort care to people who are coming to the end of life. It is not a hospital. There are certain things we don't do in hospice because we're not trying to recreate hospital. So in hospice, everybody has a comfort-focused goal and a goal of care designation. Remember the video with comfort. If that is not your own goal, if you're hoping to prolong life, then hospice is not the right place to be at. I should put that caveat in. So if you're looking for care and life-prolonging goals, that's where long-term care and other sorts of facility living are important. But if you're looking for that kind of intensive comfort support, 24-hour nursing support in the final sort of months of life, then that's where hospice comes in.
Does it cost individuals?
It doesn't. It's like being in hospital in as much as you've already paid through your taxes, so you don't pay for hospice care. There are some things you pay for as you would at home, like your own medication, and again, that's subsidized. But so some of the things that you pay for at home, you continue to pay for in hospice. but the actual, you know, meals and facility you don't pay for. And everybody has their own room and their own washroom. There's no shared rooms.
The hospice, is it more or less for people that are basically bedridden? Or is it for someone that just needs the extra attention and maybe, you know, doesn't want to spend their day in their room? They're, you know, they can be down and find an area where they can look out the windows, or maybe go for a walk in their little garden or something like that.
You're right that the vast majority of people who are in hospice are there because they're unable to manage at home, and that usually means because they've become bedbound. It's become too hard to get up and get to the washroom. So we tend to reserve hospice for those whose needs can't be met anywhere else. So if you can live at home, we're going to help you to stay home. But if you come to a point where you're bedbound, or you've got very complex care needs, maybe some really difficult medication needs, some special wounds or other things that you might be living with, then hospice can be helpful for those who are still ambulatory as well. That tends to be a rarity. But all the hospices have kind of lounge areas and common areas where people can eat together and families can cook food and kind of be more home-like than a hospital where there's only your room and nothing else.
I once heard a very simplistic definition that medical care is one of two things. It's either curative or it's palliative. And in that kind of context, my current care program is palliative. And when I have that kind of discussion with my wife to say it's palliative rather than curative, what it does is it takes away any future concern or point in time about a discussion for the need for palliative care. It will just be a slow expansion, hopefully a hell of a long time from now, but it doesn't all of a sudden introduce this, oh my God.
I think that's a very helpful way to think about it, and that's how we think about palliative care now. Is it's sort of an increment. So for some people, it's a kind of an incremental process. So for many people, we'll start with disease-modifying therapy, curative intent, and we've got just a small amount of palliative care being required in terms of the other components we need to live well. But as we come towards the end of life, more and more of our care is focused on those palliative, living well, quality of life issues, and less on the disease modifying, because sometimes there just are less things that can change our disease.
Yeah, and it precludes this sudden point.
There's no sudden point.
What's happening?
Mm-hmm. I think the old model that many people would have heard about is this idea of, yeah, I'm getting cancer treatment, and now I'm palliative. And I agree with you, that sudden point shouldn't be there. It's much more, I'm getting these things concurrent with each other. I'm receiving palliative care and disease-directed therapies. And now I'm receiving less disease-directed therapies and more palliative care. It's a smooth transition. I love your analogy.
I'm just wondering if you could talk about the gap that there might exist in your mind between the theory of the palliative care principles versus the actual practice. And what I've got in mind is the newly diagnosed and some of the mental anguish that they can go through, some of the learnings that they have to go through in a very foreign language called, medical language. And those first 6 weeks to 6 months can be quite a challenge for many men. I know that because I've spoken to them. And yet, I didn't get a sense that your palliative care is dealing with that first 3 to 6 months of time after people are initially diagnosed. That's a very, very sensitive time for several people, for many people.
It's a very sensitive time. It really is that very rocky time. A ton of information, a ton of processing to do emotionally about what's happening. And I agree with you that we have a lot of work to do on patient experience, what we experience during those first few months. It's too seldom do I hear people say, oh, that went well. Mostly I hear people say those first few months were hell. And I mean, a lot of that is to do with coming to terms and adjusting to a new diagnosis, a new reality. But we don't do a fantastic job in smoothing that out, and yet we are working on it. So Tom Baker Cancer Centre has been working on an initiative along with Specialist Palliative Care Service in Calgary to say, how can we begin to change that patient experience so it is just a tiny bit less overwhelming? How do we get people the information they need when they're ready for it and want to hear it? And we're working with patient groups. Some of you may be advisors at the Tom Baker Cancer Centre in trying to understand that experience and seeing how do we make it just that little bit easier. I find it overwhelming to navigate the system, and I've been working here in Calgary for 14 years. I can't imagine what it's like when it's your very first time encountering the system and you're trying to navigate your way through it. So it's something that we're paying a lot of attention to. I think we're still some years away from having a big impact on those first few months, but we can't but hope.
Personally, I think that when people are diagnosed, they do not go into and see, okay, what options are there? Because many different options out there, depending what kind of cancer you're diagnosed with, of course. But even then, different cancers, there are several options. And I think, personally, when I was diagnosed with prostate cancer, I decided to go in and do my own research on everything that was available. And I think it's probably the same thing with most other cancers. Go in and do your own research. It's like writing a business plan. Basically, you do your own research and okay, what are the options? So it's really, what is it? What do you do about it? That's where your research comes in, and then you make a decision. Mm-hmm. That's the way I look at my personal life and my own body. Mm-hmm. Get to know your own body is important.
I agree. I think that's what we're talking about with advanced care planning. It's thinking and learning about your own condition so that you can make the decisions that are right for you.
Absolutely. Mm-hmm. Don't leave it up to your family physicians to make those decisions. No, it's your life, so you make the decision yourself.
Mm-hmm. That's very important. I should say we did some research across Canada, and we looked at what patients' preferences were and what their medical orders were. And we found only for sick, seriously ill patients, these are patients roughly age 80, only 30% of the medical orders matched what the patient said they wanted. This horrible mismatch because people weren't talking to each other. So we're teaching the physicians, just ask your patient what matters to them, and we're empowering the patients to say, don't wait for your doctor to ask, go tell them what's important to you, because if you leave it for them to guess, we're likely to guess wrong. We tend to overestimate. In that study we found that the biggest mismatch was between people who said, I really want to focus on comfort, quality of living, I'm not that interested in length of living, and the doctors were guessing wrong, and we're focusing on trying to prolong length of life and not spending enough of the energy on quality of life. So that was one research study. So sorry, there was another question.
Yeah, sort of basically it goes back to what Stuart was saying, and that I was diagnosed now about 5 years ago, and this was just out of the clear blue. Bang, I happened to have a blood test, the PSA was up, and they said, oh, you better go in for it. I had no idea. Immediately right off the bat, I said, oh, you would need biopsy 64 PSI. That's not good. So I thought, well, how high of not good is it? Nobody would say sort of thing. And so it went on for that. For 2 years, going on 3, I had very little information. The oncologist I had at that time was not forthcoming. As I say, with my old family doctors, if I went in to see the doctor, we'd sit down and we'd talk it all out. But with them, I thought, well, they're the doctors, they know, they'll tell me what I'm supposed to know. And I'd go in and they'd say nothing. Oh, yep, okay, we'll do another one of these, and off and go. So I find, somebody said, well, if you're not happy with it, change. So I did. And the new oncologist I got is almost like my old doctors again. He comes in, we can talk, same with his nurse. So I can discuss a bit of it, but I mean, I have learned more in these last 2 years, and a great deal of it thanks to the Warriors group here. And it has been a blessing. It really has. In talking with others, and I've discovered that a lot of have higher PSAs, some practically down at nothing, and they're quite excited about it. And I think, oh, get some time in. But you know, it's the learning curve. And I went to the Tom Baker initially. This is where you go and you take these little courses, and they tell you about nutrition and all this. But it just like your little cartoon going on that road blind. I had no idea what was ahead, what to look for, whether I should be afraid of this, what I can do, you know, more to do. And so as I say, it's just driving me crazy. And as I say, Warriors were a godsend. They really, really were. And I say to all the gang, thank you very much. And for anybody else that might be listening or hearing that aren't part of this and would like that, it's a fabulous group of guys. And as I say, everybody's had different levels. Mine, I'm blessed. I have no aches, pains, nothing. I feel the same way as when it was first discovered, except that I know it's there because they say it is. And we're trying to do everything about it. The PSA goes up, they try something different, it comes down, yay, and then it starts going up. Oh, let's see what else we can do. But I mean, it's this little roller coaster. And as I say, it's now getting to have a few more directions that one can go down the roads. Oh, I've tried this, and I've tried that, and I've tried this on. Well, this works for me, and this doesn't work for me. And, you know, as I say, everybody's different.
And information is power, right? Once
Absolutely.
you have that information, you're
Absolutely.
empowered
Yeah.
to live better with your illness, yeah. Some other thoughts? Sir?
You know, talking about doctors, I go see my doctor and he's got 10 minutes for me. So he's not the team. The team is, I guess if I have a heart attack, I go to the hospital and then I get a team. And talking about cancer, it depends what kind of cancer you have. You know, I've got a son going through liver, rectal, lung, and all kinds of cancer. You know, he's got a team. He talks to me about that team, and which are good. But you know, you have to. On that team, there's so many different people that you know, who do you listen to? You have to listen to each one that looks after each part of, I guess, your body. So you know, when you get a team like that, and you know, they send stuff to the doctor, and he just gets the information, but he, you know, really he doesn't do anything with it. He may talk to you a bit about it, but it's difficult when you try to interpret what each member of that team is saying about you, and how do you do, as that gentleman says, how do you research all that? It's just about impossible. So it's a complex thing we're going through in cancer care. So it's
one piece, I mean, with respect to advanced care planning, one really important piece about that green sleeve that I saw was handed out to everybody is 2 of the forms in there are meant for whatever healthcare professional is working with you. If they have a conversation with you, or somehow it comes up about, you know, oh, you know, I want this, or if a snippet comes up, even if they only have 5 minutes, they can jot down that note, and then you take that green sleeve with you to the next specialist. They can pick up, and it's ways for them to communicate with each other, because you're the central link. So that's why the green sleeve is so important, because it at least is one avenue that some of this information can get passed and be part of the whole health picture. Because you're right, care these days is very fragmented. And so that's why the green sleeves, it's so important for it to go with you, because it's one way that doctors can sort of communicate with each other when they're not directly speaking.
well, that's right. If you have a team, they could meet, but how many times do they meet together to talk about the complex ones? You know, the simple ones are a lot easier when you have a complex one, and they do pass the information around, and you
So
know,
our
we
hope
hope
would
that
be if you had your green sleeve with your personal directive that or a goal of care designation order that's been filled in by one of your doctors, that next time you go to a specialist or one of your other healthcare team members, they'll maybe start off by, or if you say, hey, I've got my green sleeve here, they can look at it and be like, okay, I see that you're a whatever, does that still reflect what you want? And maybe it just opens a little bit of a window just to kind of keep that conversation going as more health pieces are added, as you're seeing, each member of your team. So that's the key piece about the green sleeve, is you're bringing it with you to all the members of your healthcare team. So it's one way they can communicate with each other about this.
And when you're in that, if you're alone and you're in that situation, and you go and you try to listen, how much do you hear? And he's lucky he's got a wife that's pretty proactive on that, and she still handles everything through the system. So it's a complex situation, but it's a good. I enjoyed the presentation.
It is hard if you're going through it alone, if you don't have other people in your corner. I don't know whether the Warriors group offer to go to each other's appointments, or whether you take your iPhone and say, do you mind if I record our session? Because I don't always, take in what I'm hearing from you when I'm here in my 10 minutes. Can I record it? So I've seen people do that as well, and that way you've got a little record, you can play it back again at home and re-listen to whatever new piece of information was shared. Okay, well, thank you for your time.
Jennifer and Alex,